Hi everyone, I'm Sebastiano Vacca, medical doctor and PhD student at Feinstein Institutes in New York, and today I'll be presenting you the basics of imaging in ischemic stroke. First of all, what is an ischemic stroke? Well, ischemic stroke occurs when a blood vessel supplying the brain gets occluded, leading to a reduced blood flow and subsequent tissue damage. The sooner we identify this blockage, the better the patient's chances of recovery are, and imaging is critical for rapid diagnosis and guiding treatment decisions. We can have different types of strokes, especially thrombotic ones with large vessel occlusion and small vessel occlusion. We can have cardioembolic causes, more rare causes, or cryptogenic strokes. Obviously, we have to know which artery is blocked. The brain's blood supply is divided into the anterior and posterior circulation, with the anterior cerebral artery and middle cerebral artery supplying most of the frontal, parietal, lateral temporal lobes. On the other hand, the posterior cerebral artery supplies the occipital lobes, thalamus, and brainstem. We can also categorize stroke based on the timing and especially on the time elapsed since the critical event. We can have an early hyperacute phase, which is in the first 6 hours since the critical event, a late hyperacute phase, so 6 hours to 24 hours, an acute one, 24 hours to 1 week, subacute, where is from 1 week to 3 weeks, and chronic 3 weeks onward. At each time point, the imaging characteristic will differ from each other, both in MRI and CT imaging. Here we have a non-controlled CT. This is the first line imaging due to its rapid availability, though it may appear normal in the acute phase. I invite you to take a look at it and to see if you can notice any changes. So hopefully you were able to identify this hypotenuse area on the right at the level of the coronal radiata. And as a matter of fact, hypertenuation on CT is highly specific for reversible ischemic brain damage, especially if detected within the first 6 hours. Besides that, we also have a loss of gray white matter differentiation that suggests early ischemic changes, as well as a loss of symmetry between the left and right hemisphere, and the sulcal effacement. We also have other signs more specific, especially for the MCA, as the hyperdense MCA sign that indicates a thrombus in the middle cerebral artery, or the insular sign, that is hypodensity swelling of the insular cortex. There is an early CT signs of infarction in MCA territory. But CT is not the only imaging technique that we have at our disposal. Sometimes we might also have MRI. MRI might not always be available and is time consuming, making it less routine in the hyperacute phase, but valuable in the subacute phase as well. Now, hopefully, you were able to identify what's wrong in this brain. So, there is an area of restricted diffusion on the right at the level of the coronal radiata, corresponding to a hypertense area on flare. These changes indicate an acute ischemic stroke. In MRI, probably the two most important sequences are the diffusion weighted imaging and the ADC map. A bright signal on diffusion imaging indicates restricted diffusion, that is typically due to cytotoxic edema representing an acute infarct, while a corresponding drop in the apparent diffusion coefficient confirms acute ischemia. Now, what do we see here? Hopefully you were able to identify this frontoparietal hypodense area with loss of gray white matter differentiation and effacement of the sulci, once again indicating an acute or subacute ischemic stroke. Meanwhile, why do you think these images are peculiar? Well, once again, we have areas of restricted diffusion corresponding to hypertense areas, in this case in the frontoparietal region on flare. And this is a case of acute watershed ischemic stroke. So watershed areas are those areas in the brain where two different arterial systems meet and the blood supply is reduced. Usually they are caused by cardiac emboli, and they are at higher risk for stroke when there is a drop in blood pressure. Meanwhile, on this slide, we can appreciate the superiority of MRI in comparison to CT, especially the unenhanced CT. Here we can see how everything is more clear. We can notice an occipital hypodense area with loss of gray white matter differentiation and effacement of the sulci, corresponding to an area of restricted diffusion. Once again, indicating an acute ischemic stroke, in this case of the posterior circulation. Once again, what do you see on this CT scan? In this case, we have an hypotenuse area on the right insular temporal region with effacement of the sulci and loss of gray white matter differentiation. Once again, we can appreciate how reliable these signs are for identifying an acute stroke. This was a case of an acute or subacute posterior ischemic stroke. But sometimes we might also seek help in the form of computer-aided diagnosis. And for especially MCA strokes, we have the Alberta Stroke Program Early CT score, or ASPECTS for short. That is a 10-point system used to quantify acute ischemia or non-contrast CT imaging based on the degree of involvement of the MCA territories. The ASPECT system divides MCA territories into 10 regions, deducting a point for each region involved. So a normal MCA territory scores 10, while diffuse MCI involvement scores 0. In this case, lower scores correlate with greater stroke severity and higher risk of symptomatic hemorrhage. Nowadays, you can't really talk about anything in medicine without touching on artificial intelligence, and AI, as every field, is rising as a leading component. In this case, for stroke imaging, it's expected to further change acute and not acute stroke care. There are three main use cases where AI offers potential benefits. First of all, the detection of abnormalities to improve the performance of the human reader and to increase the accuracy, sensitivity, and specificity of imaging analysis. AI can identify morphological, mathematical, and geometrical characteristics that are hard to detect for the human eye. It can also improve workflow efficiency to reduce the time to detect abnormalities and generate reports. AI can recognize the most severe condition to expedite care and reduce treatment times. And speaking of treatment, it can also optimize these treatments, especially it can aid in therapeutic decision to make triage and treatment decisions based on clinical imaging parameters, as well as in the post-stroke rehabilitation strategies. So we've made it this far without actually talking about one of the main imaging techniques in stroke care, that is perfusion imaging. Perfusion can help us in differentiating between the ischemic core, so the reversible damage, and the penumbra, the potentially soluble tissue. There are a few key parameters such as cerebral blood flow, CBF, cerebral blood volume, CBV, mean transit time, MTT, and time to peak. Some of the key findings in perfusion imaging are the match defects in CBV and MTT that suggest an infant core, or the prolonged MTT with preserved CBV indicating ischemic penumbra. Usually in early stroke stages, the extent of regionally abnormal MTT often exceeds that of abnormal CBV and CBF. These maps show smaller areas of abnormality than MTT, making them more specific for ischemia and infarction. Mismatch between abnormal CBV and CBF can help us in estimating the penumbra. And usually with modern CT scanner, CTP and CTA can often be performed simultaneously with a single contrast dose, but in many centers they're still done with two separate infusions. So we're near the end, but here are some final tips. Remember to always start with a non-contrast CT to rule out hemorrhage. Follow up with CTA and CTP to evaluate vessels and tissue viability, and when possible use MRI for detailed assessment, especially if the diagnosis is unclear or if the stroke occurred in posterior circulation. Remember, time is brain. We lose approximately 32,000 neurons per second and almost 2 million per minute. So the quicker you identify and act on these imaging findings, the better the outcome for the patient. Thanks for watching.